My name is Dr. Namir Hyder, and I practice in New York and Washington, D.C. in the United States of America. Today I'm here to discuss intraosseous and intraarticular bone marrow aspirate concentrate for the treatment of arthropathic pain syndromes. In order to treat arthropathic pain syndromes, one must first understand the functional anatomy of subchondral bone. Located beneath the calcified cartilage line forming what is known as the osteochondral unit, subchondral bone consists of cortical bone where the bone marrow and trabecular bone areas emerge. Despite the calcified cartilage layer and the cortical plate being non-porous, it is well known that communication exists between the articular cartilage and subchondral bone. In fact, if you inject contrast into the subchondral bone using fluoroscopy, you will often see leakage of the contrast into the intraarticular space. The intercommunication between the layers has been identified to play a significant and important role in the progression of osteoarthritis. The pathophysiology of osteoarthritis includes, as we know, wear and tear of the articular cartilage over time. There is multidimensional change of the whole joint inflammatory environment, with many inflammatory mediators present within the synovial fluid. Inflammation of other structures, including subchondral bone and the synovium, does occur, and this contributes to the overlying health of the joint. In the past, steroid injections have been used to treat joint pain, but as we know, these injections themselves can cause degeneration of cartilage over time. We also know that anesthetics that we use intraarticularly themselves can cause damage to structures within the joint, including the joint cartilage. Viscosupplementation has been used as well with hyaluronans injected into the bone. These have been shown to work to provide decrease in pain and improvement in function. However, we do not find necessarily long-lasting relief from such viscosupplementation injections. Significant research has identified subchondral bone as a primary starting place for pathological changes. Objective findings that we do see include bone marrow edema. We know that there is crosstalk between subchondral bone and the articular cartilage. Lesions in the subchondral tissue can ultimately affect the overall health of the articular cartilage and lead to degeneration if not properly treated. Bone marrow edema can easily be identified on MRI studies. In fact, MRI studies can show hyperemic areas within bone and areas that are unhealthy that may be amenable to treatment using either PRP or bone marrow aspirate concentrate. Treatment options for bone marrow lesions include bisphosphonates for the treatment of osteoporosis. Extracorporeal shockwave therapy has been shown to give relief when applied to joints. Total joint arthroplasty is a solution for patients that may be candidates for such procedures in joints that may be amenable to treatment, such as the knee joint, hip joint, and in some cases the shoulder joint. Subchondroplasty using calcium phosphate or polymethyl methacrylate has also been used for treatment of these conditions. However, application of such materials is not providing relief or healing of these areas where there may be bone bruising or unhealthy bone. Platelet-rich plasma, as well as bone marrow aspirate concentrate and mesenchymal stem cells have been more recently used for the treatment of pain. They have, however, also been used over many years, as we will discuss further. Astor et al. Performed a review of subchondroplasty with calcium phosphate. It was noted that significant improvement in the International Knee Documentation Committee, SCORE, or knee injury and osteoarthritis outcome score in 64 subjects, showed that there was a 70% reduction in total knee arthroplasty at 2 years. Side effects of this treatment when studied included 1 case of deep venous thrombosis, 2 cases of extravasation of cement into the joint. However, 25% of subjects still had complaints of pain despite this treatment. Sanchez et al. Compared intraosseous and intraarticular PRP versus intraarticular alone in patients with severe medial or patellofemoral osteoarthritis. Leukocyte-poor PRP, low concentrate with 5 ml was injected into the medial tibial plateau and medial femoral condyle 2 centimeters above the chondral surface. The intraosseous and intraarticular group had significant improvements in many different scales, including the Western Ontario and McMaster University Arthritis Index and the Visual Analog Scale. Fizz et al. Treated 40 patients with severe hip osteoarthritis who failed intraarticular PRP with intraarticular and intraosseous PRP. This study showed significant improvement in WOMAC as well as the Hoos scale at 12 months with no adverse events. The study showed that treating with intraosseous and intraarticular PRP for hip osteoarthritis was better than intraarticular treatment alone. Hernigu et al. Published outcomes on long-term follow-up with a mean of 12 years for young patients with bilateral knee steroid-induced osteoarthritis. One knee was randomized to receive total knee arthroplasty and the other received autologous BMAC. There were 30 patients and 60 knees injected with 10 milliliters each into the medial and lateral tibial and femoral compartments of the knee. 40 ml was injected in the subchondral bone of each treated knee. Both groups had similar scores, with 21 of 30 preferring the BMAC treated knee. There were no serious adverse events in the BMAC treated knee. The surgery knees had 1 infection, 5 cases of thrombophlebitis, 9 required transfusions, and 6 required revision surgery. Only 3 of the patients who received bone marrow aspirate concentrate received total knee arthroplasty thereafter. In Hernigu's study of the hip, published in 2018, a 30-year follow-up was looked at the outcomes for the treatment of stage 1 and stage 2 hip osteonecrosis with cellular therapy versus core decompression. 125 patients, including 250 hips with bilateral osteonecrosis, were enrolled from 1988 to 1998. The hip with the larger sized osteonecrotic lesion on MRI was treated with percutaneous cellular therapy, including bone marrow aspirate concentrate. The hip with the contralateral smaller lesion was treated with core decompression. At the most recent follow-up, an average of 25 years post-treatment, 24% in the cellular therapy group versus 76% in the core decompression group had undergone total hip arthroplasty. So as you can see, the rate in the bone marrow aspirate concentrate or cellular therapy group was much less. In fact, 2/3 less than in the group who were treated with core decompression. In addition, only 28 versus 72% also had progression to collapse on repeat MRI at follow-up in the cellular therapy versus the core decompression group, respectively. Davidson et al. Presented outcomes for 49 patients aged 10 to 17 years with osteochondritis dissecans who were treated with high-volume subchondral bone marrow aspirate concentrate. 76.9% had healing on post-procedural imaging with no serious side effects. Kasich et al. Treated 20 patients with knee osteoarthritis and bone marrow edema with subchondral injection of bone marrow aspirate concentrate and demineralized bone matrix in addition to arthroscopic surgery with a mean of 14.5-month follow-up. The VAS score was noted to decrease from 7 to 1.3. IKDC scores increased from 29.2 to 66.1, and 3 of the 4 patients who had post-procedural imaging showed improvement. The technique for intraarticular and intraosseous PRP and bone marrow concentrate injection is quite simple and can be easily described. The process includes performing x-rays initially to image the joint itself. Thereafter, I recommend performing MRI studies to look for areas of bone bruising or hyperemic pathological areas in the subchondral tissues on MRI. Once these particular areas are localized on MRI, we place needles to directly inject into those diseased aspects of the bone. In the case of a knee, we would place needles, if necessary, into the proximal tibia, either medially or laterally, into the distal femur, medially or laterally, depending on findings on MRI, into the patellar bone itself, as well as intraarticularly. And this is showing a needle that is placed within the bone into the medial tibia, and then thereafter injection of bone marrow aspirate concentrate into the area. This is an example of intraosseous injection of a shoulder. In this case, this is a 57-year-old radiologist who presented to us with severe changes in the left shoulder joint. This patient is actually a radiologist that reads our MRI studies and had been receiving only intraarticular bone marrow aspirate concentrate injections in Florida. He had called me and asked me if I could do a injection for him since he couldn't go from New York to Florida for the injection that was recommended intraarticularly. I had mentioned to him that I would suggest we not only perform intraarticular injection, but also intraosseous injection. And he agreed. We performed intraosseous injection into the diseased shoulder. And today, which is about 1 year later, the patient has a 2 out of 10 VAS score from a previous 8-9 out of 10, improved functional mobility, and improved ability to perform exercise, including weightlifting. So he's very happy with the intraosseous and intraarticular injection. We also injected his AC joint in addition, so I think it's very important in shoulder treatment to not miss the acromioclavicular joint. This is often arthritic and often diseased. So in this case, we injected intraosseously into the femur, intraarticularly into the glenohumeral joint, as well as intraarticularly into the acromioclavicular joint, and we also injected intraarticularly into the subacromial space. Now, I will note to you that I was previously performing only injection with bone marrow aspirate concentrate, but over time we have found that injecting PRP in addition to bone marrow aspirate concentrate may be giving us better results. So now we are adding both of those to our injections. This is showing another AC joint injection with contrast within the acromioclavicular joint. So just be careful when treating the shoulder not to miss the acromioclavicular joint. When treating the knee, we want to evaluate the knee to see where the disease process is occurring, and we would like to place our needle right where the disease process is worse. In this case, with this patient, we can see we're treating this aspect of the tibia. On AP view and on lateral view, we're directly injecting into that space. We would inject into this space, also inject into the femur, and then intraarticularly. And in certain cases where necessary, we would inject into the patella itself for the treatment of such pain. Intraosseous hip injections can also be performed. In this case, we're injecting into the head of the femur. We can see some extravasation of contrast. Previously, we performed an intraarticular injection during this procedure, and then we followed it up by an intraosseous injection into the femoral head. You can see that the femoral head is distorted in shape and the joint space is pretty much obliterated. We can also inject the acetabulum. So the acetabulum as well as the femur are two good targets for injection of intraosseous bone marrow aspirate concentrate as well as PRP. We can also inject into the ankle joint. In this case, it's a patient with os naviculare. Os naviculare is an accessory ossicle that is present, and this patient did very well with injection of bone marrow aspirate concentrate as well as PRP with the reduction of pain as a result of the treatment that we performed. So in conclusion, current published research demonstrates very promising results for the use of bone marrow aspirate concentrate for treatment of osteonecrotic lesions of various different joints, including the hip, knee, and shoulder. Subchondral bone can be targeted in the treatment of hip, knee, ankle, hand, foot, shoulder, and clavicle osteoarthritis. And new innovative minimally invasive treatments and procedures will change the current treatment paradigms for the treatment of arthropathies and osteoarthritic pain. Thank you very much for having me. Goodbye.